Next speaker is Dr. SUBUDHI, again, a very prolific surgeon and national figure, and who has been doing a lot towards safety and the security for the ophthalmic surgeon of today. And he is the director of Ruby Eye Hospital, Behrampur, Odisha. And he is going to tell us again something very important. There are moments when we have to move on from PHACO to SICS, and when and how to convert are going to be his pearls. On to you, doctor.
Thank you, Dr. Chitra. Am I audible?
Yes.
Am I visible also?
Yes.
Yes.
Thank you, sir. Thank you, Dr. Chitra, to give me an opportunity to speak in front of stalwarts like Dr. Abulya Sahu, Dr. Devasis, and Dr. MSR.
Yes,
thank you, Dr. Satyajit, Dr. Chitra. And also I thank Dr. Chitra to make me jump from last to the middle. As you know, tomorrow we are organizing the East Zone Conference at Puri. I invite all of you to join us at Puri. So this is a very beautiful topic has been assigned to me. You know, whatever maybe you are a surgeon, whether you're a PHACO surgeon or a SICS surgeon, but you must have a mastery on SICS. Because here, I'm seeing all the surgeons, they're doing PHACO and they are doing SICS also. So at one point of time, definitely the PHACO surgeons have to change the technique to SICS to save them from a disaster and save the patient's vision. Next. Okay. So is it changing?
Yes, it's changing.
So when to convert?
Yes, sir.
There are so many points I would say, but out of all, the most important point, the posterior capsular tear. So improper case selection, intraoperative meiosis, corneal edema, wound-related problems, excess use of PHACO and liquid fluids, and CC-related problem, and last but not the least, the posterior capsular tear. So any of these cases, sometimes we need to convert ourselves from PHACO to SICS. So basically, I would say that there are three indications. One, the posterior capsular rupture during the surgery or general dehiscence noticed during the surgery with or without a dropped nucleus. When the nuclear fragment is larger than half the size of the cataract, it's better to convert. Errant capsular axis in the intumescent cataract. The intumescent cataract is very common in our country. Sometimes you have to convert yourself. And of course, unexpectedly dense cataract, which you have not planned earlier. So while doing PHACOEMULSIFICATION, notice that it's better to convert yourself to prevent the corneal damage. So how to make this transition? So whenever conversion from PHACO to SICS is warranted, it's important first to ensure that the antechamber is well maintained with a good visco, and so that the hypotony is not there. Next, any nuclear pieces there in the back should be brought into the antechamber over the iris, because once you enlarge the incision, it's very difficult to bring the nuclear piece to the above the iris, because the pressure gradient will not support it. So steps how to go there for this conversion. If you are doing the temporal side, abandon the temporal side, go to the superior side, and if it's under topical, give a subtenon block. And of course, if you are doing a superior side, you will continue the surgery going a little bit behind your corneal incision and construct the terror. Again, you see whether there is vitreous is there or not in the antechamber. If the vitreous is prolapsed, perform anterivitrectomy either to the anterior root or parsonal, but it is better to do a parsonal vitrectomy. So because it will pull the vitreous back into the posterior segment, so that you can reduce the extension of this posterior capsule, that general dehiscence. So you can see better to put the trocar and cannula and do the vitrectomy through the posterior root. Then of course, IOL fixation. You see, inspect and see if the capsule rupture is very small, you can still continue with the surgery with the your whatever the IOL you have planned. But if the capsule is incomplete, but there's a large posterior capsular tear, better you go for the 3-piece IOL, which is placed to the sulcus. And if the capsular bag is not salvageable, it will come out. So better to remove it, and you can plan it whether it will go for a primary fixation or can secondary fixation, either scleral fixated IOL or ACIOL. So we have seen many ACIOLs till date, maybe after 20 years, 30 years, they're doing very good, excellent vision, having a 6/9 vision till date. So small video. This is the errant capsular axis. My video is visible?
Yes, yes.
Okay. You can see just it has gone a little bit very. We try to retrieve and complete the axis. And at another point, no doubt we could complete in the lower part, but still the errant capsule axis we try to retrieve, but we fail. So already it extended to the periphery, so it's better to convert here, because continuing the surgery may land in trouble of vitreous disturbance. So we gave a subtenon, and we little bit behind, we went behind and created a tunnel. There should not be any hesitation to convert yourself, because of interest of the patient.
I'm good. 500 का समोसा दो 500 कुछ बचेगा मेरे पास नहीं है, दो
Satyajit, mute yourself.
Sorry, man.
Again, single piece IOL is placed in the capsular bag and could complete the surgery without any complications post-operatively. Yes, one more video. No. It's not going. It's a hard nucleus, grade 4 nucleus. No doubt we planned for the PHACO. PHACO is going very smoothly. Little bit iris prolapse is also there. Surgery is by Praveen, I have to confess. So as you noticed, there is a small postcapsule tear. We abandoned the surgery, then we converted it to the PHACO, SICS, and we could complete the surgery without any complications. The 3-piece IOL is placed. You can see the central piece here. So to summarize, however, whatever PHACO surgeon you are, so definitely you have a scope for doing learning SICS. At the time of crisis, you have to convert yourself and do a good axis and good SICS to save yourself from the great disaster. So PHACO is revolutionary the modern day cataract surgery, no doubt, but still it's essential to be familiar with the manual SICS. There are certain cases, situations like small pupils, weaker journals, hard cataracts, and poorer edithal function all make the procedure more difficult for cataract surgeons, and timely conversion SICS will decrease patient woes and misery. Haripriya et al. And Venkatesh et al. From Arvind Eye Care have shown the safety limits are significantly higher with MSICS compared to the PHACOEMULSIFICATION in these cataract cases and also among the trainees. So thank you very much for giving the opportunity to speak about this technique in front of you.
Thank you, Dr. SUBUDHI. They were wonderfully depicting videos, bringing home some very important points for converting to PCR. I have a question which I would want Dr. Debashish, Dr. Saurabh, anyone to take. When you are converting from PHACO to SICS, would you suggest that you go to a superior plane from temporal, or temporally go on a posterior plane and do, or would you advise a posterior scleral cut being made on the temporal incision? What would you advise? Would you advise even increasing the temporal CCI, or it does not make sense at all?
No, enlarging the phaco incision is makes no sense at all.
Yes.
So definitely, I mean, we need to take a fresh incision, and it is very important, Chitra, that we fill the globe tightly, and because the scleral incision, the sclerocorneal tunnel dissections, all would require a very tight globe for a good dissection. And obviously, Dr. SUBUDHI has made the point very clear that where does SICS really help in converting from a difficult situation in PHACO, where you have a PCR and there are big fragments which are hard left in the eye. So whether you are doing whether you are using a lens as a IOL as a scaffold, even if that be the case, those hard nucleus to emulsify in the anterior chamber may not be a good idea. A lesser trauma could well be easily done to the eye by enlarging the incision, by giving a regular SICS incision, getting the fragments out, and then proceeding with the surgery with vitrectomy. And
no. Would you advise a posterior scleral cut to the temporal incision, or go to a superior scleral plane?
Posterior cut to the temporal incision. I mean, no, I mean, changing the site of incision. I don't think that is necessary, because I think because they are two different incisions altogether. So you can always go below the tunnel, the corneal tunnel of the phaco incision, and develop a separate phaco, SICS incision.
Right. Dr. Saurabh, yes, Anaga?
Ma'am, I had a question for the panelists. Like, you have a dense brown or a black cataract, and initially you think you would be able to go ahead and do a phaco. But if you decide to do an SICS, and apart from changing the incision, if you have a rhexis which is not really very big, would you do relaxing cuts in the rhexis so as to be, enable the nucleus to be wheeled into the anterior chamber? Otherwise, it becomes really difficult, and you can tear actually the
yes, Anaga, I mean, that's a very important point raised. And for beginners, I would say that doing a second rhexis would be most ideal, but sometimes the pupil comes down in these situations, and probably the visibility is not good. Multiple relaxing incision is the way out. I know you can just don't give only one or two relaxing incisions, because in that case, with the whole nucleus, it can actually cross the equator and disrupt the posterior capsule. So multiple incisions, maybe 6 to 8 in different meridians would be ideal. And you actually preserve the bag. I mean, by giving such incisions, it's not that you don't preserve the integrity of the bag. And second, these are not free tags which you will catch during cortical aspiration.
What would be the way of removal of nucleus delivery if you are caught in a situation with a PCR and you're doing SICS? What would you advise? I want any other expert panel, anybody else to suggest? Dr. Saurabh?
Hello, sorry, ma'am, I didn't get the question.
No, I said you have a PCR and you have converted and you're going to doing an SICS. what method of nucleus delivery would you advise?
Yeah,
as the
so
best?
yeah, in case of these situations where actually the nucleus material is likely to drop in the vitreous, my preferred method is visco expression, because I don't want to take any chances. I will always make a larger scleral tunnel, because here I don't want any resistance for the nucleus to come out.
Yeah.
And for visco expression, the technique that I use is that with visco cannula, I go to the deepest point, distal most point under the nucleus fragment, and I start injecting visco from there. The commonest mistake that surgeons do is that they try to form the anterior chamber first, and then they inject the viscoelastic not from the deepest part but little proximally, and that may itself push the nucleus down. So once you do that and you have a nice large tunnel, scleral tunnel, I think most of the nucleus pieces come out easily.
Okay. Dr. Deepak, if it was a premium cataract surgery and incidentally SICS has been done, and I'm sure top SICS surgeons would want to do premium IOLs too. But in this kind of scenario, like PHACO to SICS conversion, and you have planned a premium surgery, then would you still put a place a premium IOL, or would you go for a monofocal?
In the case of a posterior capsular tear and rhexis continuity being doubtful, in that situation, I definitely don't think there is a role for any multifocal. So a multi-piece hydrophobic lens in the sulcus would be the best option, with the explanation to the patients. Even in case for torics and all, if the rhexis is compromised, if you compromise the rhexis, then even it's to securing a toric lens also becomes an issue. In those situations, I think best to resort to the other monofocal lenses, multi-piece lenses.
Yes. Dr.
I
Ravinda,
think
you would...
I will just add one point. I think Deepak is absolutely right. In such situation, my first aim is to achieve, giving good emetropia for these patients. So at that point, my thought process will be how I can minimize the astigmatism and how I can predict perfect refractive error. So if I am putting in the sulcus, whether I'm going to do optic capture, so I plan. And as rightly said, like when we are doing scleral tunnel, we can also think about the astigmatism. For example, we have planned a toric IOL. Why not use this to correct the astigmatism? So my thought process shifts from the lens rather than giving a perfect emetropia, because that will make patient happier.
Yes.